dear colleagues. Congenital hip dislocation is one of the most important and challenging topics in pediatric orthopedics. In our research, we are evaluating the conventional treatment of hip dislocation in order to find the most personalized treatment protocol. My name is Gyula Domos. I'm a pediatric orthopedic surgeon at Semmelweis University, and my vision is to ensure the highest quality treatment for our pediatric patients and also to build one of the best pediatric orthopedic centers in Europe in 10-15 years. In order to achieve this aim, we have to introduce the best available treatment methods in every field of pediatric orthopedics, and we also have to work out new treatment protocols. So my current research fits well into this concept. In the first part, we are investigating the risk factors of failure in the treatment of congenital hip dislocation. Based on a systematic review and meta-analysis, we would like to reevaluate the conventional treatment of hip dislocation and to define how we can reach the best results and avoid complications. In the second part, we are analyzing the results of our treatment protocol at Semmelweis University, which is different from the international protocol, but we seem to have better results and less complications with that. So our first project is about the risk factors of failure in the treatment of congenital hip dislocation. According to the international protocol, after a failed conservative treatment with Pavlik harness, or in case of late diagnosis, a closed reduction of the dislocated femoral head is performed under general anesthesia. If the closed reduction fails, an open surgical reduction is needed. If the open reduction fails too, additional surgery, femoral and/or pelvic osteotomy is performed. But complications are quite common with this treatment protocol. Unsuccessful reduction and redislocation are the main reasons for failure. And in addition, the most serious complication of the treatment, the avascular necrosis of the femoral head, is quite common too. The overall rate of it is 10% in closed and 20% in open reduction. What we don't know is the overall rate of failure and the risk factors of failure. But if we could identify the cases where the conservative treatment will probably fail, we could skip the conservative step and perform a closed reduction immediately. Thereby, we could avoid several complications and unnecessary interventions. And if we could select the cases where the closed reduction is likely to fail, we could skip the closed reduction step and perform an open reduction immediately. Based on this scheme, we could perform a complex surgery if the open reduction will also probably fail. So our questions are, what are the risk factors and the overall rate of failure in the treatment of congenital hip dislocation? We are investigating 3 subgroups: children with conservative treatment, with closed reduction and open reduction. The intervention is the presence of risk factor, the comparison is the absence of risk factors, and the outcome is the rate of failure. So our hypothesis is that certain risk factors increase the rate of failure in the treatment of congenital hip dislocation. I performed a systematic search in 3 databases. My search key was about hip dislocation and reduction, and I found more than 12,000 records and almost 200 eligible full texts were selected. So these publications cover the 3 subgroups: the conservative treatment, the closed reduction, and open reduction group. Regarding the risk factors, we found 86 publications, and we also found 113 other publications with only data with the rate of failure. So first we are investigating the closed reduction group with almost 100 eligible full text. In the publications, we found data about 5 different types of failure. The primary failure consists of 2 subgroups. One is the intraoperative failure, when the dislocated head is not reducible under general anesthesia in the operating room and an open reduction is performed. The other is the postoperative failure, when only the postoperative MRI or CT scan shows that the primary reduction attempt was not successful. But after a successful primary reduction, redislocation of the femoral head can also occur during or after the 3-month spica cast period. And the last type of the failure is the overall failure. In the publications, we found 61 risk factors, including anamnestic data, gender, age, laterality, previous treatment, clinical and imaging exams, and treatment features. We have results regarding the rate of failure in all 5 types of failure. The primary failure rate was 13%, the rate of redislocation was 8%, and the overall rate of failure was 20%. Regarding the risk factors, we have some significant results. The grade of dislocation significantly influences the rate of failure. In low dislocation and in moderate dislocation, the rate of failure was significantly lower, and in high dislocation, the rate of failure was significantly higher compared to the other groups. And we also found another important result. The rate of failure was significantly higher in preoperatively irreducible dislocations compared to reducible dislocations. So there are several strengths of our study. This is the first systematic review regarding the risk factors of failure, and this is the most comprehensive meta-analysis in the topic of hip dislocation treatment. And we were also able to identify high-risk patient groups. But there are some limitations too. Publications do not consistently investigate and define these failure groups, and the treatment protocols were not exactly the same in all institutions. So the conclusion of our study is that the risk of failure is high in close reduction in high dislocations and in preoperatively irreducible dislocations. And we also found that the failure in bilateral cases is rather bilateral than unilateral. So the implication for practice is that in high-risk patient groups, open reduction is advised instead of close reduction to avoid complications. But randomized clinical trials could clarify what other risk factors influence the rate of failure in high-risk patients. So after analyzing the close reduction group, we have already started to investigate the conservative and open reduction groups as well. In my second project, which is actually the 4th one, we are analyzing the data of our patients with congenital hip dislocation treated by primary complex surgery. At Semmelweis University, we don't use the international protocol in the treatment of hip dislocation in case of late dislocation and after a failed reduction because of the high rate of failure and avascular necrosis. During the treatment, we would like to avoid the forced reduction of the dislocated femoral head because it can damage the blood supply and cause avascular necrosis. So as we cannot select the cases where the closed and open reduction steps will probably fail, we skip these steps and perform a primary complex surgery with open reduction, shortening femoral osteotomy, and joint reconstruction. Although we perform more surgeries than the other centers, we can minimize the rate of failure and avascular necrosis. So in this project, we are investigating the exact rate of complications and the late results. We are collecting the data of our patients treated at Semmelweis University from 2008 and 2019 with a minimum 2 years of follow-up. Patients are children with congenital hip dislocation after failed conservative treatment in case of late presentation and in case of syndromes, treated by open reduction and femoral osteotomy. We treated 116 patients, 72 girls and 44 boys, and most of the cases were unilateral in girls, and almost half of the cases were bilateral in boys. So these are the 2 main topics that we are investigating during this year. And I brought a quote from István Szepsi, who is a famous and internationally recognized winemaker. His words that the highest quality is our moral duty is also a very important rule in medicine, especially when we treat children. Thank you for your attention.
I would like to ask that, do you have any data as when the primary diagnosis was recognized in these children? With ultrasound or physical examination?
You mean at our center or
no,
generally?
No, in generally. Where it was very divergent?
No.
No. Because the aim is to recognize it as early as we can.
Yes, of course.
As you know it. So there was no data when they recognized the hip luxation or subluxation of these hips.
Probably there are, but this is not in this project, so I can't answer it.
Exactly. Just for the comparison, because if there are centers where there were earlier ultrasonographic examinations, and maybe in other countries there are later ones, that it's hard to compare these data.
Yes, correct.
I have seen just one X-ray in your presentation. Did you use always the same plate for your surgeries, or
yes?
Yes.
Yes, but it works.
Okay. Because formerly we didn't use this plate, so it seems we have used the longer, the fixed angle plate.